Very good evening to all of you. I welcome you all for this second academic session of Neurometabolic and Neurogenetic SIG of AOC in India. Last week we had 4 interesting case studies on neurometabolic disorders, and today we'll be having 4 interesting cases on neurogenetic disorders. And we have got 4 presentations from Rainbow Children Hospital, Hyderabad, GMC Trivandrum, AIMS New Delhi, and from North Bengal Medical College, Siliguri, West Bengal. I request our President, Dr. Shafali Gulati ma'am, to introduce the experts and the moderator for today's session. Over to you, ma'am.
Yeah, thank you. I welcome you all. And from conundrum to clarity, and now genetics is coming in the future. And we are very happy to have 4 cases from across India and how genetics has helped in the diagnosis and management. And we are very grateful to our experts, Professor Madhulika Kabra, who's the leader of genetics in India, and Dr. Gauri Pasi, who's my senior by 6 years, right, Dr. Gauri? And I've been there in Indore for so many years, and professional par excellence, and has, like the logic she puts in everything in daily practice. It's something which I've been admiring for years. And the moderating the session would be Dr. Lokesh Lingappa till 9 o'clock, and after that Vaishak, because Dr. Lokesh has to join for another meeting at 9. So Vaishak, you stand by for taking over as the moderator of the session. Now, over to you, Dr. Lokesh.
Yeah, thank you, Dr. Shifali, for that introduction. I think this one, I think in the interest of the time and the audience time as well, because beyond 1 hour, it's going to be difficult for people to sustain attention. So we will try to keep it to minimal this one, 8 minutes to 9 minutes of presentation, and then another 5 minutes of discussion by the experts, and while we are taking the questions as well. So beyond 15 minutes, I think we should stop and try to answer on the chat box for all the questions. I think that way it will work better, so that all the 4 cases get equal time, and then it will be smoother to moderate. So I invite the first case to be presented by Dr. Anas, and then we'll take the questions later.
Sir,
we have Dr. Das, Dr.
Suman Das, sir?
Yes. Sir, I will be presenting the first.
Okay, sure. Go ahead.
So, thank you, sir. So, good evening, everybody. With my respect and regards to the Honorable President, Madam, the Honorable Secretary, Sir, the esteemed experts of today's meeting, all the members of the Neurogenetic Special Interest Group, and all the attending delegates. Now, I would like to start my presentation today. My case is about a child with multiple seizure types. Now, I will start my presentation with the video of the child before the disease started. Now, just play the video. This is the video of the normal child, and you would see that the child is alert, he's playful, and trying to babble a few monosyllables. It is at 5 months of age. You have seen that the child was absolutely normal, and prior to the onset of the seizures, this child was born out of normal delivery. He cried at birth. He was born out of a non-consanguineous marriage. He had an uneventful antenatal period, an uneventful neonatal period, and he was having a normal growth and normal global development till the 5 months of age. Now, the disease started at about 6 months. Please, the next slide. The disease started about the 6 months of age, when he had a first episode of seizure in the form of an atypical febrile seizure with an episode of fever with a lower respiratory tract infection. In that episode, he had multiple types of seizures on the first day, so it was an atypical febrile seizure. He was admitted to the hospital and discharged 1 or 2 days later, and he went fully recovered. But when he went home, within 2 weeks, multiple seizures types started, and these seizures, they gradually increased in frequency. He had afebrile GTCS. He also started to have clonic seizures involving both upper limbs, and he also started to have myoclonic jerks. Now, these myoclonic jerks were polymorphic jerks. They were generalized, they were focal, they were multifocal. And these jerks, they used to occur in clusters, and they used to occur in single jerk at a time. Please, the next video. Please play the video. In this video, you will see that there will be jerks, jerky movement of the hands, which will occur in clusters. See the jerky, the jerks, the cluster of jerks, myoclonic jerks in the hand. The next video. In this video, you will see that there will be jerks, myoclonic jerks involving the head associated with inconsolable crying. Recurrent episodes of myoclonic jerks involving the head and associated with inconsolable crying. In this video, you will see that the myoclonic jerk is in the hand is occurring in only single time. The previous video showed the clusters of jerks in the bilateral upper limb and the head jerks, and in this video, you will see a single jerk. So as I told, there were polymorphic myoclonus, focal, multifocal, and generalized, and there was associated regression, the global regression of all milestone. The patient lost both his mental and the motor milestones, and the child was initially floppy, but later spasticity developed in all his 4 limbs, and gradually he became unresponsive to visual and auditory stimuli. The next slide, please. Now, regarding the family history, there was no family history of any epilepsy or any developmental regression, and the child was having an elder sibling. Her elder sister was absolutely normal. The next slide. Now, in the physical examination, the salient points was that he had no dysmorphism. There were no neurocutaneous markers. There were no organomegaly. The child was having a truncal hypotonia, spastic, but there was spasticity in the limbs with bricks, jerks, and extensor plantar response. The next slide. Now, this is a picture of the slide which was taken at the time when the child was having floppiness. You will appreciate that the child is having a frog-legged posture because of the initial floppiness, but later I will show you pictures where the child had developed spasticity. Please, the next slide. Now, to summarize the disease phenotype, this child was having an infantile onset disease after an episode of normal growth and development till 5 months of age. His disease was comprised of refractory multiple seizure types, which comprised of atypical febrile seizure, GTCS, clonic seizures, as well as myoclonic seizures, and associated with a global regression. The next slide. Now, to localize the focal myoclonus, the multifocal myoclonus, the GTCS, and the clonic seizures of the upper limbs, they were localized to the cerebral cortex. But since the child was also having generalized myoclonus and also the axial myoclonus was present, the possibility of involvement of the brainstem, that is a brainstem myoclonus, was also kept in account. The next slide. Now, at the time when we saw the patient, the child was on levetiracetam, valproate, and clonazepam, but there was no reduction in the seizure frequency of the child. The next slide. Now, what were the possibilities? The next slide. And now, so we considered the first possibility of the early onset infantile epileptic encephalopathy, and this phenotype was matching with that of Dravet syndrome because it all started with an atypical febrile seizure, and thereafter multiple seizure types appeared. But another possibility we also kept in mind was that of new onset refractory status epilepticus, because the child also started with an atypical febrile seizure, but within 2 weeks multiple seizure types started, and sometimes they went into a status, both GTCS status with a GTCS and also myoclonic status. The next slide. The next slide, please. Now, we did a CT scan. The CT scan showed that there was a diffuse atrophy of the cortical atrophy as well as the subcortical atrophy. The subcortical atrophy was mildly asymmetric because the ventricle dilatation was slightly more on the left side than on the right, and there was speckled calcification in the subcortical white matter. The next slide, please. Now, the MRI, this is a T1 sequence which shows that the atrophy was predominantly frontotemporal. The asymmetrical subcortical atrophy is seen, but the yellow arrows, you see that the cerebellum, they are less affected than the cerebral cortex. The next slide. Now, in the first picture on the left hand side, you see that the peripontine and the perimesencephalic cisterns are very prominent. This can occur when there is an atrophy of the brainstem. The cerebellar vermis is also showing mild atrophy, and the frontotemporal atrophy is again appreciated. The next slide. Now, here in the coronal cuts, there were no abnormal signal changes in the hippocampus. The entire brain parenchyma did not show any definite signal change. It was only suggestive of a diffuse atrophy. The next slide. This is a T2 weighted image which shows that there were no abnormality in the signals, but it was only showed a diffuse atrophy. The next slide. Now, here you see that the sagittal cut, the inferior pons was affected more than the superior pons, but the superior cerebellar hemisphere was affected more than the inferior cerebellar hemisphere. So it was a pan-encephalon atrophy involving the cerebral cortex, the maximum. The brainstem was atrophied, and also the superior cerebellar, the hemisphere, superior portion of the cerebellar hemisphere, and the vermis, they had also undergone mild atrophy. The next slide. Now, the EEG, it showed that there were predominantly bilateral frontocentrotemporal spikes and sharp wave discharges. And these they were appreciated both in the bipolar montages and also in the referential montage. The next slide. This monopolar montage also shows the predominantly frontocentrotemporal spikes. The next slide, please. Sometimes these frontotemporal discharges were generalizing. Now, the next slide. This is again the evidence of a generalized discharges. The next slide, please. Now, we investigated the patient. The routine investigations were all normal. The blood TMS, urinary GCMS was normal. Serum ammonia, urinary and arterial lactate was normal. ABG was also normal. The CSF routine studies were normal. But to our surprise, we saw that the CSF and the serum autoantibody profile, it was done by ELISA method. It came to be GABA B positive. Now, the next slide. And now we considered the possibility of autoimmune encephalitis against the GABA B receptor antibodies. Now, but this was quite a big surprise to us because as far as we knew, this GABA B receptor autoimmune encephalitis, they occurred in elderly males above 50 years of age. They are usually paraneoplastic, and in pediatric age group, they are very rare. The next slide. We started on immunotherapy, methylprednisolone and IVIG. The next slide. Now, we searched for pediatric case reports of anti-GABA-B. The first case report was of a 3-year-old child. Another case report was from India, which was associated with COVID-19. And another case report was of an 11-year-old child. And the majority of this GABA-B receptor antibody encephalitis, they were associated with the bilateral medial temporal lobe signal changes, and they were usually associated with a limbic encephalitis-like picture. But there are a few cases which one or two cases which reported normal MRI too. The next slide, please. Now, so we searched for the odd points against the GABA-B encephalitis. The early age was a very odd point because majority of these patients, they presented above 50 years of age. The evolving multiple seizure types, it was an odd point against GABA-B encephalitis because majority of the patients, they presented with complex partial seizures only. But in our child, there were myoclonic jerks and clonic jerks and GTCS. These myoclonic jerks have never been described before in GABA-B encephalitis. Now, the lack of signal changes in the medial temporal lobe was also an atypical feature for GABA-B, and normal CSF is also atypical because majority of the patients, they usually have elevated proteins. So the next slide. We considered the other possibility of early onset infantile epilepsy, and we followed this algorithm where a vitamin supplementation was advocated, and to treat for vitamin responsive early onset infantile epileptic encephalopathies. And for pictogenic cases, these chromosomal aberration or microdeletions were considered, and for symptomatic cases, other structural cause or metabolic causes were considered. But in the routine metabolic screening, arterial lactate and ammonia were normal in our case. Structural etiology, there were no focal lesions in MRI in brain, only there was diffuse panencephalon atrophy. We also added the vitamin supplementations. The next slide. Whatever was available in our hand, pyridoxine, pyridoxal phosphate, biotin, folinic acid, thiamine, riboflavin, methylcobalamin, we had tried all, but the child did not respond to anything. We continued the immunotherapy because the patient had been was having GABA-B receptor antibodies positive in CSF. The next slide. Here we are seeing a case which was having initial developmental milestones, later developing multiple seizure types, and he was having a normal metabolic profile, no structural etiology, a gross atrophy on brain, in the brain, no toxin exposure, and no response to vitamin trials. And EEG was suggestive of the epileptic encephalopathy. In keeping all these in view, we also considered now a genetic etiology. Now, please the next slide. Now, we were considering which genetic test to be considered. And now, since this patient was not having any dysmorphism, not having any neurocutaneous markers, no structural lesion in brain, and the child was having no early onset developmental delays. So all the developmental delays started after the onset of the seizures. So we chose our next generation sequencing over a chromosomal microarray with reflex karyotyping. So we sent a next generation sequencing. The next slide. We got the result that there was a pathogenic mutation, the likely pathogenic mutation in the NRROS gene. The NRROS full form is negative regulator of reactive oxygen species. We did the segregation analysis in the parents, and they were found to be the heterozygous carriers of the same genetic mutation. The next slide. This NRROS mutation, it results in a disease which is an ultra rare disease known as the Senibac, which signifies seizures, early onset with neurodegeneration and brain calcification. This gene was having an OMIM locus of 615322. The next slide. Now, this negative regulator of reactive oxygen species, this gene is responsible for the expression of the tumor growth factor beta on the microglial cells and the astrocytes in the brain. As we all know, the tumor growth factor beta, it is a negative regulator of inflammation. It is an anti-inflammatory cytokine. So in presence of mutation of this NRROS gene, the tumor growth factor beta receptor will not be adequately expressed over the microglia and the astrocytes. So these microglia and the astrocytes would be recurrently activated. Now, activation of the microglia would result in liberation of very harmful cytokines, the cytotoxic cytokines, and that results in the death of the neurons in the brain. These NRROS mutation, this was resulting in the gross neurodegeneration. Now, since the neuronal degeneration results in the exposure of the neuronal antigens to the immune system, in mice experiments, NRROS knockout mice, they developed fatal allergic meningoencephalitis. But this autoimmune encephalitis following NRROS mutation was not previously described in humans. It was only previously described in mice experiments. The next slide, please. Next slide. We continued our immunomodulation. We continued the monthly cycles of methylprednisolone. We gave 6 cycles of methylprednisolone, and then we put the child on the tapering dose of oral prednisolone. And we are continuing the tapering dose of oral prednisolone for 1 year. We also started a ketogenic diet, and after immunotherapy, this child, and thereafter the antibodies and negative is modulated. The next slide. Next slide, please. Now, the therapeutic outcome, the immunotherapy was significant. After 6 months of immunotherapy, we got significant response. The migraine seizures, they grossly reduced in frequency about 2 to 3 times in a week. It used to occur. All the other seizure types, they disappeared. But what happened was that the child developed decortication. The stimulus sensitive decortication, the spasticity remained in all the 4 limbs. There was no response to verbal or auditory stimuli. The child developed microcephaly. The only positive response was that there was a significant reduction and almost stoppage of all the seizure types. The next slide. Now, there was a significant improvement.
I think we can quickly wind up, Dr. Suman.
Yes, sir. Very few slides are left. Yes. The EG was all the spike and wave discharges, they had completely disappeared. The next slide, please. The EG, we repeated the EG, it repeatedly showed that all the epileptiform discharges had disappeared. The next slide. Next slide, please. The next slide. Next. So this is a picture of the decorticated posture of the child. The next slide. Next slide. So this is a list of the various types of mutations that have been described in association with NRROS mutation. Before our case, only 10 cases have been reported, and ours is the 11th case. The next slide, please. Now, this first report was by Dong et al., who reported 6 individuals from 4 families. All had the multiple types of seizures have been described, and the majority of them died. Only 1 child lived till 9 years old. The next slide, please. And another Smith et al., he reported 3 children. After they were normal in the first year, they became all symptomatic at the 2nd year, but the majority of them they expired. The next slide. Now, this is we published this case in the Journal of Pediatric Epilepsy as the first case of anti-GABA-B autoimmune encephalitis in NRROS mutation, which was previously described in mice and not in humans. The next slide. So our article added the first case in humans, which was previously described in the mice experiments, and immunomodulation was a possible therapy for Senibac, and a mutation we described was a novel mutation. It was not described previously. It was a nonsense mutation. All other previous they were missense mutations, and we added this mutation to the evolving genetic conundrum. And my take-home message is that the genetic etiologies can predispose to other types of etiologies. In our case, it was an autoimmune encephalitis. Thank you.
Thank you very much for that case, which has lots of twists and turns in the diagnosis and the management. And now I would invite Professor Madhulika Kabra ma'am to give her comments.
Thank you very much. Very interesting case. I would like Gauri to initially comment on the clinical aspects, maybe MRI and the EEG, and then maybe we can discuss a little bit about the genetic etiology.
Hi, Dr. Suman. That is a beautiful case. You worked it up
Thank
really
you, madam.
well.
Thank you, madam.
And you analyzed it so well, and you've gone very systematically. At just one point that even with neuroregression, he was perfectly fine till 5 months, and then he started regressing.
Yes, madam.
So, and had multiple kinds of seizures, and within a few months he had become in a completely vegetative state. So
Yes.
All the videos, no?
I would
Just
say that
otherwise it just generally takes 5 minutes.
now, instead of doing a series of multiple investigations which we do, probably it is most cost effective and time effective to straight away go for a whole exam.
Yes, madam, but we wanted to do the whole exam, but the patient party, they took time to gather the money. So the child was there with us, so we investigated, and because all the investigations, they are free. All the other investigations, they are free of cost in our hospital.
Okay. So, second, I just wanted to discuss 3 clinical points which will be useful for students basically, because this is basically a sort of discussion for students. One of the videos which you showed looked very like West syndrome. They were occurring in clusters and axial tonic clusters with a lot of uneasiness on the face. Why did you call it myoclonus? It's like an infantile spasm, epileptic spasm. He did have
Yes, ma'am.
focal
But
myoclonus.
in video, I only projected on the yes, but the inverse is that the entire, along with the flexion of the head, the entire body will undergo flexion. But in this case, I showed only the head jugs. The entire body did not undergo flexion in that case. They were this video was of an axial myoclonus only, and the patient in the infantile spasm patients, they do not have any focal myoclonus, but this patient was also having focal and multifocal myoclonus. I showed the multifocal myoclonus involving both the hands, which occurred in clusters. I also showed the myoclonus involving both upper limbs, which occurred only once. I showed 3 videos, and the head jerks, they were only axial myoclonus without any flexion movements of the upper limbs. So we called it myoclonic jerks rather than infantile spasm. And these jerks were a much more shorter time interval than the infantile spasm, which has a longer duration than these myoclonic jerks. The duration of infantile spasm is longer than for the myoclonic jerks, madam.
This child, I am sure he had myoclonic jerks as well. I'm sure he had multiple types of seizures, but one of the videos was very like a epileptic spasm, the one which occurred in clusters. Second point I wanted to make was that your first differential was a Dravet syndrome, because he started with a febrile seizure, then he started having
Yes.
then he had myoclonus. I wanted to make a point that if you review the recent ILA syndromic criteria, so in that, one of the things which is exclusionary for Dravet is that if you have epileptic spasms. That was just a point I wanted to make. Second, question for you, just for the students, that how do you differentiate myoclonic jerks, which are cortical, subcortical versus spinal? Clinically.
In cortical myoclonus, the cortical myoclonus, they're usually focal. They usually occur in the distal parts of the upper limbs and the face, which has the maximum motor homunculus representation. In the subcortical myoclonus, they're usually the subcortical and the brainstem myoclonus. They're usually axial myoclonus or generalized myoclonus. They are usually auditory stimulus responsive, whereas the cortical myoclonus, they are responsive to somatosensory stimuli and this visual stimuli response.
Yes, so cortical, if they're action induced myoclonus, they're typically cortical. Auditory
Yes.
myoclonus typically subcortical or
Subcortical, yes.
Spinal myoclonus will never involve the face. That is.
Yes, spinal myoclonus, they can be segmental or they can be proprietary spinal myoclonus.
Yeah. The third one, no, I think now I'll ask Dr. Madhulika to take over.
Very interesting case. I will just, there's one comment in the chat box saying that why NCL was not considered here. So like NCL can present like this, they can present with myoclonus, but I don't think there were any visual issues. And I'm not an expert in this, but the MRI was also not very characteristic of NCL. Am I correct, Gauri?
NCL will have progressive atrophy, but purely cortical atrophy.
And cerebellar involvement is very classically seen in the infantile onset. Yeah. Okay, so my comments, like you have a variation and you have a matched phenotype, so there is no doubt about the correlation of the genetic diagnosis with the clinical diagnosis, though it's a novel variation, but it's a termination variation, it's a likely pathogenic variant. My curiosity was that is there any correlation? You said that in mice you have some evidence with the immune dysregulation and positivity, I mean autoimmune encephalitis associated with this particular variation. So do you think the response to seizures was actually related
Yes.
to the autoimmune encephalitis, which you are considering as a separate entity, or in the pathway somewhere, because there's a mechanism which you explained, the response to seizures was because of that. Maybe the mechanism are going to be the same, but did you think about this?
Madam, here in this case, the NROS mutation itself was predisposing to autoimmune encephalitis.
That's right. Yeah, so
Yes.
does it predispose to autoimmune encephalitis?
Yes, because it predisposes to autoimmune encephalitis because the pro-inflammatory milieu that is created in the brain that results in the destruction of the neurons and the exposure of the neuronal antigens to the immune system. This predisposes to the autoimmune encephalitis.
Specifically, this anti-GABA, anti-GABA antibody, GABA B antibody has been described in animal experiments also, positivity.
No, madam. In animal experiments, they did not specify the antibody. On that autoimmune encephalitis, the allergic meningoencephalitis, it was a pathological finding.
That's what I understood.
They did not know the specific antibody.
Yeah, you're still thinking there are two things happening, and the response to therapy may be either actually because he had autoimmune encephalitis or the mechanism which has been described in the
Yes, because this leads to a pro-inflammatory milieu in the brain and
understood that. Yeah, thank you very much. So these were the two comments. And then
Thank you very much.
Hello,
Thank
can
you.
I ask a question?
Yes, sir. Yes, sir.
Yeah. This is Brajesh Udani. Just a very interesting case, but I have a couple of questions. How was the CSF GABA B? I mean, was it done by ELISA? I heard.
ELISA method, sir.
The problem with ELISA in these antibodies is it can be falsely positive. So, for example, NMDAR, for example, all these things are cell-based assays where you actually use.
Yes.
So it may be. This was not a positive call. I mean, that's it's possible. I'm not saying, but usually I'm talking about GABA based. It is NMDR, all these antibodies are mainly done with
cell-based assay, but we do not have that in the hospital. It is
but
ELISA is
I'm not saying it's criticism or something. I'm just saying that maybe
yes, sir, they are more specific because false positive is common in ELISA.
Exactly. Second possible point I had to want to make was that I didn't see your videos. I'm sorry, I'm not late, but I want to ask you. I mean, any patient, example, have severe epileptic encephalopathy. Um, you know,
I cannot hear the question, sir.
what I'm saying is any patient with any epileptic encephalopathy due to any cause. And I take that
Yes.
point, if, for example, in patients with spasms with secondary to any particular genetic cause also, steroids may work, because they have when you give steroids, you basically reduce the corticotropin and all that, whatever theories I mentioned, and then you get a response to bad EEGs and steroids, I mean, and in non-specific response. So is it that the response was because of response to the, rather than immune modulation, it was more of a response to steroids, which we normally give for many bad seizure disorders?
Yes, many epileptic encephalopathies do respond to steroids, sir. But in such cases, the response is much earlier. In our case, we did not get much of response in the first 6 months. As we continued the steroids, after 6 months, we started to get the responsive reduction in the seizure frequency. Not an early response, which we see in other epileptic encephalopathies, which respond quite fast to steroids. But in our case, the response was not so fast. It was rather protracted.
Okay, fine. Thank you.
Thank you. Thank you for that
thank you, sir.
Presentation and the interactive sessions. We'll move on to the next case.
Thank you, sir. Yes.
So to all the case presenters, we'll be circulating certificates once the sessions are done. So we request you to send in your email IDs to Dr. Kamte or Dr. Gulati.
Thank you. I think we shall stick to the time. I think we are already react by almost 20 minutes. We shall try and manage within the time frame. Thank you.
Dr. Mom, yeah, okay.
Good evening, respected faculty members. Is my screen visible?
It is visible. Could you go to the full screen, please? Yeah, okay, perfect.
So a case of infant with neuroregression, importance of keeping focus on eye of the bird. A 4-year-old female child born to third-degree consanguineous marriage. She presented initially with delayed development and stiffening of all 4 limbs. She had motor and cognitive delay at initial presentation. From 2 years of age, she gradually regularized, currently non-ambulatory and bedbound. Her neck holding was attained at 5 months, rolling over at 8 months, sitting independently at 14 months, after which she gradually lost her milestones, currently no neck holding. Transfer of objects at 9 months, currently she is not reaching out for objects. Speech, she attained bisyllable babbling at 9 months, currently she does not have any meaningful words. Stranger anxiety is present, fixing and tracking is present, recognizing parents. She cannot localizing to sound as per the history. So her motor age is 3 months, that is 7% TQ. Speech 6 to 7 months, that is 14%. Social 6 to 7 months, 14%. Overall, it's a case of global development delay with a motor slightly more than cognitive delay. She has feeding difficulties, motor solids, comfortable with mashed and liquids. She is tolerating oral feeds well. She is not requiring any tube feeds as of currently. The stiffening of both upper and lower limbs, which has gradually progressed to current level. The first child was a term child. She had no perinatal issues, but on day 4, she had developed sepsis. And the child succumbed on day 6. The child was not evaluated at that time. Our case is the second child. Mother is in no care of hypothyroidism or thyroxine. She had uncomplicated dengue fever in the second trimester, for which she was admitted for 1 day. She had oligohydramnios for which emergency LSCS was done at 34 weeks. A baby birth weight was 2 kgs. She cried immediately after birth, and ICU stay in view of respiratory distress requiring HFNC for 2 days. On examination, head circumference 45 centimeters, that is less than third centile. Stranger anxiety was present, cooing and social smile was present, fixing and tracking well. She does not localizing the sound, rolling of saliva is present, cortical fisting on pull to set, head lag is present, no weight bearing on made to stand. Generalized hypertonia, dystonia, and predominant dystonia more than spasticity in both upper and lower limbs. On DTR, where bilaterally brisk, fundus was normal. Summary. Its case a female child born to third degree consanguineous marriage, development delay, both motor and cognitive, hearing defect, gradual regression of all milestones, microcephaly, dystonia, no seizures. So at this point of time, we can localize it to deep gray matter and pyramidal involvement because of the dystonias and the spasticity. And there's pairing of the cortical involvement as there is no seizures. Differential at this point of time. So possibility of IEM was considered. Small molecular disease is a possibility, but organic acidemias though have dystonias, but usually they present in neonatal period. They may have acute regression, but they have acute regression, but the child had subacute regression. Amino acidureas can also have neonatal onset and seizures as well. Dystonia plus minus. Mitochondrial is another possibility, considering the hearing loss. Developmentally with regression, dystonia, and ataxia. Biotin thiamine responsive basal ganglia is another possibility with dystonias and regression, but the predominant feature seizure is not present here. Another possibility of medical syndrome was considered, considering the hearing loss, dystonia, feeding difficulties. Although these are quite non-specific, but these were the initial differentials that were considered, and child was investigated appropriately. Plasma lactate was done, which was high, 38.8 mg per deciliter. Plasma ammonia was normal, bicarbonate was normal, plasma homocysteine was normal, TMS, which was done, was normal, urinary GCMS done in the acute period was normal. In view of suspicion, doubt of hearing defect, hearing assessment was done. HB Bera showed bilateral moderate to severe sensory hearing loss in both the ears. MRI brain was done. This is a T2 axial image. There's some degree of cerebellar volume loss as we can see the foliate. And in the brainstem, there is hyperintense, heterogeneous hyperintense lesion in the striatum with sparing of the mid-dorsal pontine region. Diffusion restriction image of the same child. Here, the diffusion restriction in the striatum, bilateral patchy with similar ADC. So this was the characteristic image that led us to the diagnosis. So here there's a striatum hyperintensity due to hyperintensity with sparing of the mid-dorsal putamen. So considering all these clinical and radiological images, the possibility of Medill syndrome was considered. So whole exome sequence was sent for the same. Clinical exome was sent initially. We had specified for the Medill syndrome, and but the lab did not pick it up. The initial gene that was identified was SLCA1-2. Which was heterogeneous depth of 62, that is a missense mutation. There was no phenotypic match. So retesting with whole exome sequencing, the initial was clinical exome. So we retested with whole exome sequencing at a different research lab at Delhi, which did not show the SERAC1 mutation, what we are suspecting in this case. But in view of the strong suspicion clinically and radiologically, repeat in August 2023, we took the decision to repeat the whole exome sequencing at different lab. This is the report. It showed a homogeneous missense variant in the exon 3 of the SERAC1 gene. with a depth of 59x. The variant was classified as uncertain significance because the similar variant was it's a novel variant. So when to suspect McDill? There's history of psychomotor delay, neuroregression. The child may have neonatal onset hepatopathy, but our child did not have. There may be clinically microcephaly, drooling, dystonia, spasticity, truncal hypotonia, feeding difficulties, sensory hearing loss, myopathies, and neuropathies can be present. Hypoglycemia can be a presentation and neonatal period. There's lactate elevation, which is present in our case. One odd thing was GCMS is supposed to be high, urinary 3-methyl glutaric acid is supposed to be high in McDill syndrome, but the urine GCMS what we had done initially did not detect any methyl glutaric acid. So takeaway message: McDill can present with normal urinary GCMS. It's important to have differentials based on clinical phenotype and neuroimaging before going for genetics to increase the pretest probability. This also states the importance of persisting to find the answer and going ahead with the reanalysis with the data multiple times when you have a clear phenotype in mind. So clinical exome, whole exome, and exome max. Probably the reason why initially the clinical exome did not pick it up could be because although the depth and coverage is supposed to be there, sometimes on an average it's more than 100%, 100x, but sometimes it depends on the probe, what the quality of probe and quality of coverage. So it may be possible that certain regions may get missed. That is why it is important to repeat it when we have a strong suspicion of the clinical phenotype. That's it. Thank you.
Thank you, Dr. Anas, for that presentation. I think we had this challenge with this child. We were very sure clinically, radiologically, it is McDill syndrome. But we at 2 labs, we got it as negative. So we are trying to think, is there other differential? Our geneticist, Dr. Sara, is also in the meeting. Dr. Sara, you are there?
Yes, sir. Good evening, sir.
Yeah. Can you just add 2 lines before Dr. Madhulika Kabra would comment?
Yes, sir. Good evening to all the esteemed panelists. So a good case presentation. So over here, this was a VOUS variant and it was matching to the phenotype as what Dr. Anas has given the list of symptoms which were matching. And the most important was the MRI, which clinched the diagnosis. So the variant was matching and we could say that this is a variant which is the causative in the child. And probably the previous time it was not picked up, as Sir has said, that it could be because of the poor coverage, not well covered in the CES, and probably not an established lab previously. So we are still trying to find out. We have spoken to the lab as to why it was not covered. They're yet to get back to us.
Yeah, thank you. Professor Madhulika Kabra, ma'am. Actually, these are the challenge.
Yeah.
Any comments? Yeah, one comment is that have you checked whether this 3-methyl glutamic aciduria, is it do these McDill patients have it intermittent? They secrete this thing, or shouldn't they always have it? That's one question we need to check out.
Yeah.
And second is that today's age, why not straight away go for a whole exome instead of doing a clinical exome?
Yeah.
Overall, it's worth doing a whole exome straight away.
Yeah, true. The first one is, yes, they can be very low excretors sometimes, and they can have intermittent as well. During crisis, they might have a better this one. As such, they have very low levels of excretion as compared to most other organic acidurias. And the second question is, this was done almost a year back, the initial testing. And it was a family where they were wanting to have a low-cost testing. When we were very sure that this is the diagnosis, we wanted to reduce the cost. And even actually after that also, when we sent this fresh sample to another lab in Delhi, we couldn't get an answer. So I think we still have to keep learning. And ma'am, any answers? What do we do?
So the issue here is that what I understood was that first a clinical exome was done, then a whole exome was done, and exome max was also done.
Yes, ma'am.
Okay, so see, these terminologies are very confusing actually. So
Yeah.
actually speaking, when you are talking of clinical exome, theoretically
Yeah.
speaking, you have all known genes, right? But
Yeah.
this would also vary from place to place. But then, truly speaking, all the labs, I think in India, when we
Yeah.
say a panel or when we say a clinical exome, they are actually doing a whole exome. And then it's
Okay.
kind of a virtual panel. So they will give you result on whatever is their clinical exome panel, or say whatever is their microcephaly panel. So they would do whole exome and then they will analyze data for you according to your need. So that's what the panel is here. It is not that you have a panel of say microcephaly and you would expect a better coverage for some particular genes. It would be similar to what you have in whole exome. So it's likely to be low. The other issue here is that and then one slide I saw was reanalysis. So there are two things. One is that you did a clinical exome. Second thing, you did a whole exome, and then you did a exome max. So this exome max is again confusing. Earlier it was being used for if you have a, I mean, if you have exome sequencing along with CNVs. And now many labs have exome max when you are including mitochondrial also in this. So better terminologies to use are if you are using clinical exome, then whole exome. And then now the other terminology which is used is whole exome with copy number variations. So this is, and then you add mitochondrial, and different labs have different names to this. So the reason here could be that what I understood was that this diagnosis was suspected upfront and you wanted this gene to be analyzed. So I think it is always a very good idea in case you are asking for a clinical exome. It's a good idea to ask beforehand to the lab that is this gene covered in your panel or your clinical exome, and even if it is whole exome, what is the coverage like? So that is, I think, very important. So the answer was found after reanalysis and you got the raw data. Is that correct?
No, ma'am. Actually, after doing the exome max, then we got this answer.
You got this, huh? But you
Yes,
could have
ma'am.
got it on whole exome sequencing.
Yeah. Yeah.
The test was not very bad actually. Coverage, we really don't know how much that gene was covered.
Yeah.
So then on reanalysis, many times you get that information. Even in life, because it's a known gene, it should have been there on clinical exome also. So, but this happens. I mean, this is not that it would not happen. This can
Yeah.
happen, definitely.
Yeah, no, that's what just to highlight how when
Yeah.
we are so sure
Yeah.
and then we think this is possible.
Yeah.
Nowadays, at least the whole exome sequencing cost is slightly less. We can afford to send
Yeah, it
most
is
of the
not.
patients.
Yeah. So as Gauri said, maybe upfront whole exome would have been done in this particular case.
And one question is whether to do the variants in the parents, because it's a who's.
Yeah. So if it's a VUS, if it's a VUS, you have to do it in the parents.
Yeah,
There's
it's been
no
done.
doubt about it.
Yeah.
Parents of carriers?
Yeah, we are waiting for the results. Just recently we got these results. We are waiting for the parental segregation.
Because the phenotype is
This is a
matching. So
consanguineous.
it's, yeah, consanguineous marriage phenotype
Consanguineous
is
couple.
exactly matching. So it's very, very likely that, I mean, this is related to the phenotype. That's what it looks like.
Yeah.
May I ask a question, please? This is Rashmi Kumar from Lucknow.
Yes, ma'am.
I just wanted to ask the presenter that why did why not a leukodystrophy or something which would present early on? Why was differential? Why was it not included in the differential diagnosis?
Dystonia.
LCL was also considered, ma'am.
Your
But the child
IEMs, like you're narrowing it down to IEMs, that means the small molecule defects and mitochondrial disorders. Even without an MRI, you were just talking about these things. So I just wanted to know, like, why not keep a broader differential when you've got mostly long tract signs and white matter signs?
Leukodystrophy was also a possibility, ma'am, but the dystonia was the main. I mean, clinically, dystonia was the most jarring thing that was coming out, along with the hearing, at least the perceived hearing. But yes, you're right, ma'am. Leukodystrophy is also should have been considered as.
I agree that once the MRI is available, then you will not feel it, but earlier on, yes.
One
Yes.
clinical point against leukodystrophy before the MRI is that he had microcephaly.
Okay. Okay, so that was significant, huh?
Just for the students to come out. Of course, it should come in your differential.
Very rarely leukodystrophies can have microcephaly like in Krabbe's, but otherwise microcephaly is an odd point.
Yeah.
Good evening, sir. Dr. Verma is there. I just saw him. Sir, you can make some comments, please.
Thank you so much, sir, for joining, sir. We are really grateful and honored.
I missed the clinical part. I just joined.
Okay.
So I will.
Maybe for the next case, sir.
Next case. Yeah, sure. We can move on to the next case then. Thank you, Dr. Anas.
The only point I wanted to make that parental sequencing more useful in where you suspect dominant disorder. Because the mutation in the baby will be a different one. In consanguineous marriages, the from the child only, or you don't need to sequence the parent that much. From the child, it will be homozygous, unless it's a compound heterozygote. So dominant disorder where you suspect in the West, parental studies very important. In our country, they are not that important. They are important in certain cases. So that's a comment I would like to make.
Thank you, sir.
Dr. Rashmi, yeah.
Yeah, before you make it full screen, I just wanted to say that we had decided last time that we will be giving certificates to all those who will be presenting, and they will be mailed to you, all of you. Yeah, for all of them till even for the neuromuscle session.
Good evening to the distinguished faculty. At the outset, I would like to thank for the opportunity to present in this forum. This is a case of development delay with a mixed movement disorder and potentially treatable by prompt genetic diagnosis. Coming to the case scenario, she was firstborn of a third-degree consanguineous marriage, born as full term with adequate for gestational age and born LSCS, cried soon after birth with no history of an ICU admission. And she presented 1 year of age with a history of uprolling of eyeballs, noted ever since she was 4 months of age, with occasional deviation of eyes to either side and chronic posturing of all limbs. She also had history of irritability, excessive sweating and drowsiness, and had history of constant. She had attained social smile by 6 months of age, and but had not attained the head control even at the presentation, and had bidextrous approach, but no grasp of objects, and she used to babble with no monosyllables. And on examination, her eyes were aligned and she was able to track the examiner. Her faces and general movements seemed to be hypokinetic with no facial expression most of the time. And she had axial hypotonia, spasticity of all limbs, hyperreflexia, myoclonic jerks, and frequent dystonic posturing of the limbs were there with a distal predominant tremor of the upper extremities. And her mother used to give a history of her deviation of uprolling of the eyes and deviation of eyes to one side, exacerbated once a child is being taken outside in the sunlight, and which used to get aggravated towards the evening hours and used to relieve by sleep. There was a benefit of sleep. In the morning hours, it was found to be decreased. Upon investigation, her MRI of the brain showed mild dilatation of both lateral ventricles, otherwise normal, and her EEG showed no correlation for the movement disorders she was having. And a routine CSF examination, cardiac evaluation, hematological parameters, creatine kinase levels, ammonia, lactate, and prolactin levels were all normal. And her other metabolic investigations, including serum phenylalanine levels, phenylalanine to tyrosine ratio were normal, and TMS also was normal. And other electrophysiological investigations like now conducted study, BERA and VEP also were normal. Since we have got a child who had presented with a significant cognitive and motor development delay with no perinatal history and with the presence of multiple movement disorder and especially in the background of a diurnal variation, we suspected a neurotransmitter deficiency and genetic investigation was done and NGS showed homozygous deletion of SPR gene which was reported likely pathogenic and was consistent with the sepiapterin reductase deficiency. After the genetic confirmation, we started the child on levodopa-carbidopa combination with folinic acid and 5-hydroxytryptophan. And at the age of 2.8 years, the child was able to walk. Like currently, the child is walking, running normally, and is able to climb stairs 1 foot at a time, and is able to speak in short phrases with 2 words, and able to engage in conversation with her family members, and maintain all throughout maintaining the eye contact, and even able to write some letters and numbers. And a second line treatment plan was considered with the dopamine agonist and MAB inhibitors, and a third line treatment plan of sertraline and melatonin also was kept. This is a child at 1.5 years. Approximately 6 months after starting the treatment, child had started walking without support. And this is the child at 2 years, was able to run. And this is the child at present is almost normal and is even able to write numbers and letters. Sepiapterin deficiency, reductase deficiency results in significant neurological deterioration due to severe dopamine and serotonin deficiencies in the central nervous system caused by a defect in the synthesis and regeneration pathway of tetrahydrobiopterin. It typically presents with a history of diurnal fluctuation and with the movement disorders, which is L-dopa responsive, and there will be associated cognitive delay, seizures, and oculogyric crisis. There is a consensus guidelines for the diagnosis of tetrahydrobiopterin deficiencies put forth by the International Working Group on Neurotransmitter-Related Disorders in the Journal of Rare Diseases in the year 2020, which almost delineates the clinical presentation of the various types of tetrahydrobiopterin deficiencies and management. And the sepiapterin reductase is one important enzyme which is involved in the regeneration as well as synthesis pathway of tetrahydrobiopterin. This tetrahydrobiopterin is a cofactor for important enzymes like tyrosine hydrolase, which converts tyrosine and ultimately results in the formation of dopamine, and tryptophan hydrolase, which is important for the formation of serotonin. And hence, the deficiencies of these enzymes results in dopamine and serotonin depletion, and also other imbalance between norepinephrine and epinephrine, other neurotransmitters. And as well as this tetrahydrobiopterin is a cofactor for phenylalanine hydrolase, which converts phenylalanine to tyrosine, and the deficiency of hyperphenylalanemia, which itself is neurotoxic in various mechanisms. And these tetrahydrobiopterin deficiency is a group of 6 main disorders, including autosomal dominant GTP cyclohydrolase 1 deficiency, that is Sekawa disease, which is dopa responsive disorder, and it's autosomal recessive variant. And third one is 6-pyruvol tetrahydrobiopterin synthase deficiency, then the sepiapterin reductase deficiency, dihydropteridine reductase deficiency, and the pterin 4-alpha carbinolamine dehydratase deficiency. The last 3 are mainly involved in the regeneration pathway of the tetrahydrobiopterin predominantly. And in case of sepiapterin reductase deficiency, this usually present with a significant developmental delay, cognitive and motor development delay, and there will be axial hypotonia and extremities hypertonia. And there can be epilepsy also, and multiple movement disorders like dystonia and oculogyric crisis and Parkinsonian features also can be predominantly present associated with sepiapterin reductase deficiency. The characteristic feature of this is the presence of diurnal variation, which is also present in autosomal dominant GTP-CHD, that is the Sagawa syndrome. These two have diurnal variation, and Sagawa, which is also the most most common type of presentation of the tetrahydrobiopterin deficiencies, which usually present with the minor illness like gait disturbances or kinesiogenic dystonia, and with no almost normal development. And PCDD, that is carbinolamine deficiency disease, that is actually all even during the later years, it can be presenting normally with just diabetes mellitus in the later years, MODY. And other disorders like other autosomal variants of autosomal recessive variants of tetrahydrobiopterin deficiency usually have this severe cognitive and motor development delay. And this epileptic reductive deficiency in addition has autosomal this autonomic dysregulation and other endocrine disturbances also, and psychological and behavioral disturbances also can be present. And the dopamine deficiency associated with this results in the movement disorders like Parkinsonian features, dystonia, and oculogyric crisis. And the reduced level of epinephrine to norepinephrine ratio results in the autonomic dysfunction. And the serotonin deficiency manifests as temperature instability, mood changes, and sleep pattern disturbances. So basically, the presentations in form of multiple movement disorder in the background of a predominant cognitive and motor development delay in the absence of a significant perinatal event, and on examination axial hypertonia and hypertonia and exaggerated reflexes in the SBs with autonomic dysfunction, presence of autonomic dysfunction should raise a suspicion for this tetrahydrobiopterin deficiencies, and when especially when there is presence a history of diurnal fluctuation. And levodopa carbidopa combination can be given to replenish the dopamine, and 5-hydroxytryptophan to replenish serotonin. And usually 5-methyl tetrahydrofolate deficiency are found along with the tetrahydrobiopterin deficiency, which can be proved by checking CS of concentration for this. But since it is technically difficult, we had empirically started the child with folic acid. And in cases of hyperphenylalaninemia, usually seen associated with other tetrahydrobiopterin deficiencies diseases, a phenylalanine restricted diet can be prescribed. But in this case, in sepiapterin reductis, since phenylalanine levels will be normal, no need of phenylalanine restricted diet. And treatment of Segawa disease with levodopa usually results in complete disappearance of all symptoms. And even though the treatment of other neurotransmitter diseases doesn't completely disappear symptoms, it can ameliorate up to some extent after accurate diagnosis. And ideally, the CS of neurotransmitter pattern, serines, and monoamine metabolites should have been sent before sending the genetic analysis. But it's very difficult since tests are not available in our country. Most of the tests are not available, and when available, they are expensive, and the specimen needs to be snap frozen. In the case of sepiapterin reductase, usually CS of sepiapterin levels will be very high, and the levels of homovanillic acid and 5-HAA are usually found low. This neurotransmitter disorder usually manifests due to disturbed monoamine transmission in the neuronal synapses. And the manifestations can mimic other movement disorders like lysosomal storage disorders and cerebral palsy, paroxysmal disorders, and usually can be misdiagnosed. A detailed clinical examination, keeping a high index of suspicion, and doing appropriate investigations, including genetic analysis, helps in the diagnosis. Here, the treatment made a dramatic difference in the child's life, and the child is near normal now. And the specific treatment along with the levodopa could be given to this child since the diagnosis was confirmed by the genetic test. Thank you.
Good presentation, Dr. Rashmi. I've got 3 simple clinical questions for you. One, how do you differentiate an oculogyric crisis, which is a very good marker for a neurotransmitter deficiency, from a seizure?
It is consistently present, and the child might be doing other things during the event.
Yeah, so one is much more prolonged than a seizure. And second, the sensorium remains normal during that time, like you said. Second question is, in an why do neurotransmitter deficiency disorders have oculogyric crisis?
Due to the dopamine deficiency.
Yes.
As a manifestation of dopamine deficiency.
Good, very good. Third question is, there's a simple biochemical test which is used sometimes as a screening test for neurotransmitter deficiency disorders. What is that?
Serum phenylalanine levels.
That's not, yeah, somebody's mentioned in the chat prolactin. So, yeah, it can sometimes be elevated. And why are they elevated in neurotransmitter deficiency disorders?
Again, due to dopamine deficiency.
Yes, normally dopamine suppresses prolactin, and if there's a relative dopamine deficiency, there'll be an elevation of prolactin. Well, over to Dr. Kaplan.
Prolactin was normal, madam. We have done that.
Yeah, it's not very specific and it's not always present, but it's just a simple screening test. Dr. Kaplan.
Yeah, very interesting case and another example of, I mean, based on your genetic testing, you can treat these patients. So, I mean, it would not have been possible unless you had this diagnosis. My only thing which I want to comment on is that your exome sequencing revealed a deletion, right?
Yes, ma'am.
So, how do you go about it? Do you need to confirm this with something, or you just go with this report? Do you have any idea if exome sequencing can pick up copy number variations? Deletion variations?
Copy number variations, large deletions, exome sequencing might not reveal. We would have to go out with MLPA microarray.
So most of the time, because you will not be able to know the exact coordinates from which region to which region there is a deletion, right? And if it's a bigger deletion, then you may have other manifestations also depending on what all genes are there in that particular region. So if you see, even if in this report, if you go through the report, I'm sure they must have written that you confirm it with another method, right? So it could be MLPA, it could be a real-time PCR, or it could be something like a chromosomal microarray. So that's kind of confirms if you detect a copy number variation. But now with the technologies and the kind of pipelines they are using for analyzing the data, there are many publications now which say that at least 75 to 80% of these copy number variations can also be picked up on exome sequencing. Obviously, in genome sequencing, all these would be picked up, but then in exome sequencing, these can be picked up. But then most of the time, they would suggest that we should confirm it with another method. So that was the only comment I had. Sir, would you like to make any comment here, Dr. Verma? I'm not sure if sir is there. Okay, thanks.
Sir is mute, I think.
Okay, right.
Now we speak.
I have no comment. No comment.
Yes, sir. Okay, sir. Thank you. So we can go to the next case.
So thank you, Dr. Rashmi and Dr. Marinipan, for that excellent case presentation. Before going to next case, I have a doubt actually. Was there a route for biotin supplementation, or is biotin available in the market for supplementation?
Vishak, what is the question? What is available?
Biotin.
Biotin, no. Actually, the phenylalanine level is normal in this case. So sapropterin is not indicated. And again, I don't think it is available. Maybe, madam.
Sapropterin can be obtained from the UK, but it is very costly. It costs 3,000 rupees a day. I've tried it for some of my patients. They cannot afford it.
Yeah.
Thank you, Dr. Mary ma'am, for that. So if there are no further questions, we'll go to the next case. So I invite Dr. Akash from AIMS New Delhi to have his presentation. Dr. Akash, you can share your screen.
Is my screen visible, sir?
Yeah, it is.
Okay. Good evening, everyone. Today we'll see a case in which the history literally clinches the diagnosis. So quickly moving on to the presenting complaints of a typically developing child who is 12 years old. She had complaints of paroxysms of abnormal jerky movements with a gradual decline in cognition since 5 years of age, along with incoordination and tremulousness since 5.5 years of age, and difficulty in ambulation since 9 years of age.
Dr.
So,
Akash, sorry to interrupt. May I request you to start your video, please?
Yes.
Yes, you can go back to your presentation.
So these seizures were predominantly sudden, generalized, and rapid jerky movements with 10 to 20 episodes per day. And there were no precipitating factors not preceding by any urges, and they were suggestive of myoclonus. And the child also had infrequent episodes of other seizure etiologies in the form of tonic and tonic-clonic seizures. And there was a decline in cognition in the form of easy forgetfulness and inability to understand even simple commands, and not able to read the alphabets which he was able to read before since the onset of myoclonus. And the child also had behavioral issues in the form of disruptive aggressive behaviors. So this followed on, and in the following next 6 months, she had increased clumsiness with the wobbly gait and tremulousness of fingers, which was worsening with approaching the target. So it was suggestive of an ataxia along with tremors. And the child gradually had falls with walking and was non-ambulatory by 10 years of age. So all these symptoms were insidious in onset and were gradually progressing. So we have a typically developing child till 5 years of age, which was followed by myoclonus and a cognitive decline, which was then having ataxia with tremor, followed by falls and loss of ambulation by 10 years of age. So coming to the negative history, there were no other movement disorders, and there was not any aggravation or relieving factors, no cranial nerve involvements or autonomic dysfunction, hallucinations, delusion, no rash or photosensitivity, no waxing waning course or episodes of worsening with intercurrent illnesses, no past history or trauma or past measles infection. The child was immunized through age, and there was no adverse prenatal history. So with this, we have a syndromic diagnosis of a progressive myoclonic epilepsy with a neurodegenerative pathology, and we can localize the lesion in somewhat with the cortical gray matter and the cerebellum. But we had neglected one important part of the history, which is the family history. So in the family history, we can see the index child. So this is the 12-year-old child having a disease onset at 5 years of age. So we can see the presenting complaints of this child, which is myoclonus, cognitive decline, behavioral issues, and ataxia. And moving on to that, father, he had ataxia, dementia, reduced speech, psychiatric symptoms, then seizures, which the grandmother also had similar symptoms. So we can see from the grandmother to the present child, the age of onset of the disease is like gradually becoming younger and younger earlier in onset. So it is demonstrating an anticipation phenomenon. And also we can see the paternal inherited diseases. They were little earlier in onset and had a more severe outcome. So without this family history, we would have kept a etiological diagnosis most commonly as a NCL, as a PME phenotype most common, and MERF, DRPLA, and other non-PME phenotypes like epilepsy with myoclonic atonic seizures, while SSP autoimmune post-infective usually have a chronic course, so they are not fitting in the first history itself. With this history, family history, we have a autosomal dominant anticipation phenomenon with a paternal transmitted more severe disease. So our final etiological differentials would be narrowed down to DRPLA with an addition of SCA. So both of these have trinucleotide repeats and an anticipation phenomenon, with epilepsy with myoclonic atonic seizures having autosomal dominant features but not the anticipation phenomenon. So moving on to the general examination, the head circumference was normal. There was no microcephaly, no other neurocutaneous or KF-ring or signs were present. And the CNS higher mental function was affected. The child was not oriented, and there was only inconsistent response, and the child had very poor verbal output. And cranial nerve examinations were insignificant, while the power was at least 3/5 in both the upper and lower limbs. The there were some white matter involvement signs with brisk knee and ankle jerks with bilateral extensor plantar reflexes. With cerebellar signs in the form of tremors, titubations, and nystagmus, there was no organomegaly. So to summarize, it was a 12-year-old typically developing child till 5 years of age who had an uneventful perinatal period, immunized to age, with myoclonus followed by cognitive decline and cerebellar and pyramidal signs. So with our anatomical localization, add a minimal white matter involvement also. Our etiological differentials don't differ with the examination much. So we move on to the investigation part. First, the MRI is at the level of the basal ganglia. The T2 axial section shows normally preserved cerebral cortical matter, while there is significant atrophy of cerebellum and the pontine body, and in this atrophy of the superior cerebellar peduncle as well. Now we'll see the video EEG with the photic stimulation. So the low to mid frequency photic stimulation revealed a photoparoxysmal response with photosensitivity as well. The child having a myoclonic jerks, which are induced by the visual stimulation, photic stimulation. So we can see this 16 hertz stimulation currently, but it started from 3 hertz itself. So this is the 18 hertz photic stimulation. You can appreciate the axial myoclonus. So coming to the etiological differential, dentatorubral pallidoluysian atrophy, DRPLA, we have ataxia, myoclonus, cognitive decline with a family history of dementia and autosomal dominant inheritance with anticipation. So among these three, DRPLA fits our cause. So we go on with the targeted PCR for the CAG repeats. So the first number is the first allele from the ATN1, and this is the second allele. So we can see the 57 CAG repeats. So it is a heterozygous, and one is having a pathogenic number of CAG repeats. So it is an autosomal dominant trinucleotide repeat, and this is in the grandmother. There is a 57 number of CAG repeats. Then in the father, there is 58 repeats, while in this daughter, the current child, it is 68 repeats. So the disease onset has been progressively earlier. So we have pathogenic CAG expansion in ATN1 genes in 3 generations, each generation more severely affected than the previous. With paternal inheritance, more pathogenic repeats with early onset severe disease, suggestive of DRPLA. So just a little summarizing points on the other PMEs. So NCL is the most commonly suspected of the PMEs. It can have onset either in congenital, early, late infantile, juvenile, as well as the adult forms. But most all of these are autosomal recessive, with DRPLA only being the autosomal dominant one, and MERF being a mitochondrial maternal inheritance. So in Lafora, we have an onset at around 12 to 17 years, and it has a relentless dementia with visual hallucination as well as occipital seizures, while Ulrich-Lundberg disease has a onset in the first decade, but it does not have a relentless progressive dementia. While MERF can have other organ involvement, sialidosis has coarse facies with choroid spots, and SSP has other extrapyramidal symptoms also usually, and EEG shows GPETs. So in DRPLA, there's usually a childhood as well as a adult presentation. So quickly we'll go to few points on DRPLA. So it is commonest in the Japanese population with CAG nucleotide expansion causing a toxic gain of function and having a juvenile as well as an adult onset presentation. And basically it has anticipation phenomenon, and other most important part of anticipation is that paternally inheritance is more toxic. So we have a normal number of CAG repeats in the age of 6 to 35, while 48 and above are pathogenic, and ranges from 20 and above are mutable ranges. So those who are having like non-symptomatic 20 CAG repeats, they can in the subsequent generations demonstrate this disease phenotype. So DRPLA can be either juvenile onset as well as an adult onset. Juvenile onset has a PME type of picture, while the adult one has a Huntington type of picture with dementia, choreoathetosis, and psychiatric symptoms, ataxia being common to both. So there's another concept of somatic instability peculiar to the trinucleotide repeat conditions, where different somatic cells and even at different time points can show different number of trinucleotide repeats. And the neuropathology shows intranuclear inclusion bodies, astrocytosis, and the along with the cerebellar atrophy and pontine atrophy we are seen in the MRI. At older age groups, we can see the lateral part of the globus pallidus getting atrophied as well as the subthalamic nucleus. So dentatorubral pallidoluysian atrophy. So this is the MRI picture. So in older age groups, it can have white matter signal changes also, periventricular, while the brainstem and cerebellar atrophy we can see in earlier age also. EG can show spike wave discharges as well as polyspec generalized discharges with photoparoxysmal response up to 27.3%. So treatment is mainly supportive, but there are promising upcoming modalities using antisense oligonucleotides to reduce the toxic CAG repeats. So timonersen has been tried in Huntington's. So it has also have CAG repeats, though it is not successful once the disease sets in the recent trials had shown. They are now trying it in a pre-symptomatic Huntington people, but the future for therapy of DRPLA lies with the ASO therapies. Thank you.
Good presentation, Dr. Akash. Very nice. I think the key message is that take a very good family history, 3-generational family history, solve many of your problems. I have only one question for you.
Yes,
which is the genetic test which can pick up both point mutations as well as triple repeats?
Sanger?
Pardon?
No.
So theoretically, whole genome sequencing can pick up triple repeats also. And then the newer third generation sequencing method like nanopore sequencing, Oxford nanopore, they are supposed to be able to pick up both triple repeats as well as point mutations. But whole genome is probably going to be able to pick up triple repeats.
Yeah, I think he has forgotten. We had the presentation, about the personal genomes we had before that. What do the experts say? And Vinod Skaria very much clearly mentioned about this, that whole genome will be having all that, even the CNVs and everything also. That is why it's going to be coming up with the cost reduction. Gautam.
Yeah, very nice presentation. Yeah.
Gautam will just, Gautam was moderating, वो बोल देगा फिर उसके बाद हम.
Your comments.
So basically, among the various neurodegenerative and neurogenetic disorders, these PME phenotypes has got a special place, and this case highlights the importance of considering the various differentials in a child presenting with PME phenotype. So most commonly we see SSP, that is subacute sclerosing panencephalitis, and NCL as the common forms of NCL. And in this particular case, the highlights of this case includes the family history. That's a significant family history which shows both an autosomal dominant inheritance with anticipation. So that is the clinching point in this particular case, along with the MRI findings which are characteristic of DRPLA. So this case basically highlights the importance of family history.
So very important message here would be that with the family history, I mean, you said it's autosomal dominant, but with the clinical phenotype, you made a clinical diagnosis.
Yes.
Otherwise, even with the family history, we would have ordered something like exome sequencing and we would not find anything. So here, there is a value of doing a targeted test. Somebody had asked that why in the previous case, a targeted test was not done for that particular gene. So if you have a very specific kind of suspicion based on the phenotype and the investigations which are available, you can do a targeted test and for maybe for even for Sanger. But then if the gene is too big, in that case also we sort of go on to next generation. So as of now, for triplet repeat disorders, though theoretically whole genome sequencing would actually come up and it will cover everything, but as of now it has to be a targeted test for checking for the repeats. So that's what the message is. So everything is not answered by whole exome sequencing. So many times we do see cases where whole exome has been done and it's clearly a disorder which has to be picked up by a different kind of test. Very good examples are triplet repeats. SCAs and all. Many times we see patients get done the exomes and we do not get the answers. So I think that's an important message here. Sir would like to give some message here, Dr. Verma, please.
You have given a good message.
Okay, thank you, sir.
But nice to see the faces of all of you.
Thank you, sir. Same here.
Smiling.
In the US as of now.
Yes.
Good morning, sir. आपका good morning है अभी sir.
Yeah, good morning.
Thank you. So really nice, very interesting. Learned a lot. Thanks.
Ma'am, any take-home messages you would like to give to the participants? And Mansi, you did not share his certificate. हाँ, मैंने बोला इसको भी देना है. ऐसा नहीं है कि हाँ चलो अब नीचे कर दो, बंद कर दो. Yes. Yeah. So take-home messages.
Yeah. So yes, sir.
Madhuri Hegde was telling me.
Sir,
Madhuri was telling me they have a test which will pick all the triplet repeats.
Yes, sir.
I think there is this little variation of the exome. So some of the pick up all the triplet repeats. In our laboratory in India, it is not yet being picked up.
Yeah. So whole genome they are trying to, pick up.
Yeah, whole genome will pick up.
Whole genome will pick up.
Yeah. I find in the US, whole genome becoming more popular, but in practice, it is still not covered by insurance in every case. Okay. So there are many. I was asking one expert, he said, I have not ordered any because the insurance doesn't cover. Yeah. But I find in research, at least, everybody is going for the whole genome.
Yes.
There was a very interesting paper from Broad Institute from Boston Children on epilepsy, whole genome, rapid whole. So it's all coming on to rapid whole genome.
Yes.
All these are rapid. So they found it very useful in almost 50% of the epilepsies.
Sir, take home messages, sir. आप पहले बोलेंगे. Verma sir, take home messages. आप फिर Dr. Madhulika, फिर Dr. Gauri. Yeah.
The take home message from you.
From
you, sir, first.
Me, okay. So I think the time has come, like all the big institutes, they must have their own sequencers and their own experts to report. I think what is suffering most of our laboratories, they do not have medical people to advise them on the importance of the variants. So we go wrong in interpretation of the variants. And I think I've been thinking today that we need to create a network in India so that we have a special, say, we have Madhulika group specializing in a particular thing. So any complicated case goes to her. Because I was reminded, because I had a case of CEH. When there's a duplication of the gene, it causes, any other mutation loses its pathogenicity. So this report somehow went to UK, and the laboratory in the UK sent it to Exeter because that's the one localized that they will do CH. So they were experts, and they were able to give comments which not possible for all labs. I think we need to do this through the IAMG, or through either ICMR or DVT to create the network.
Yes, sir.
Sir,
Because
at a
in
small
neurology,
Sir, at a small level, as a part of Association of Child Neurology, and also there is there's a platform being created, by IGIB, and we had a collaboration with the IGIB earlier from the Center of Excellence at AIMS and in the Child Neurology Division, and with under the AOC and AGIS, there's a platform being created where obviously we'll be roping in the experts of genetics like ma'am and all, and the genetics like Vinod Skaria was making making the platform in which anybody from Pan India, the AOCN or anybody can upload their genetic reports, and then it will be analyzed by a group of experts. So once that panel, that site is ready, the group of experts, like ma'am, we'll ask ma'am to get the people, the experts from the genetic side, and from the clinically, from the neurology side. So we will just have so that a clinical genetic phenotype genotype correlation can be done, and all those complicated cases can be understood and analyzed. So that will be have to have a lab genetics, clinical genetics, and the pediatric neurologist on the board. So, and they will be sharing on the platform. So that will be a platform just practically being completed, and then we'll be launching it. So that time we'll obviously request you and ma'am to be there, and we would have the panel of experts from the clinical genetics. Ma'am can say from the lab side they are collating, and we'll have from pediatric neurology also a core of experts for that. And anyway, there is an SIG also, which we are having this month, neurogenetic neurometabolic SIG special interest group from AOCN. Ma'am, sorry, your comment, please.
No. So, I mean, all these cases, there were different cases and gave different messages. I think the important thing still is that phenotypic characterization and family history. So I was really happy to see a good pedigree which was made by Akash. So if you're suspecting a neurogenetic disorder, for that matter, any genetic disorder, make a pedigree first. And I think pedigree gives you all the visual impression if you write clearly the phenotype also at the bottom. So a good clinical phenotype, a good pedigree, and then choosing the correct test. I think it was demonstrated very, very clearly in many of these cases. So these exomes and genomes are really, really helpful, but then we should not do it as over-the-counter tests. Think about the case and then decide which test is to be done. Though in certain situations, very non-specific phenotypes, and we are not able to make any diagnosis, there are some points which are favoring something. There, they really come to rescue, and without those tests, we will never ever will be able to make a diagnosis. And we can end up having cases where actually therapeutics come into picture, and that can be life-saving for the patient. So it's really a boon, but we have to really use them very judiciously. So that's my message here. Thank you. Gauri.
I agree with Dr. Madhulika. That's deep phenotyping. From a clinician's point of view, be extremely good in your history and examination, know clinical science very well, and understand the approach to problems. That's my message.
Anybody else from the SIG wants to say anything about the SIG? Rashmi, Dr. Rashmi? Dr. Rashmi, anybody else from the SIG wants to say? Vaishak?
Yes, ma'am.
Any message?
Different, and each case had a different message. So the message already has been clearly mentioned by Madhulika ma'am and Dr. Gauripasi and Parma sir.
Yeah, that's Rashmi Kumar now. Very good cases, I must say. And, finally, and all of them kind of different each other. So it's good learning. Thank you so much.
Thank you. And I think it's important that these all cases are reiterating, as all of the experts have said, that we cannot have patient coming in and you are advising on whole exome. You have to take the history, and history is going to give you 90% of information. Then you're going to get supportive information by the examination, and then go ahead. And the investigation should be supporting or refuting what you were thinking. It is not going to be a picking a needle from a haystack and just going to do that. I think that is something to understand. I thank you all the presenters for wonderful cases, and all of them from the preceding ones also will be sent their certificates. Mahesh, you can please close, and we will continue this SIG for this whole month. Anyway, all the academics will continue non-stop. So you please keep your Wednesdays free. Mahesh, you can do that.
I thank all the presenters and their mentors today for a wonderful case discussion on neurogenetics. Next Wednesday, we'll be having a guest lecture by Dr. Astik Biswas. The topic is very interesting: radiogenomics of malfunction and cortical development. So it will be a very interesting talk. I request all of you to attend and make use of the talk next week. We'll be starting at 8 p.m. Next week. I'll be sending the link and the details on WhatsApp and email. So with this announcement, I'd like to close the meeting.
Thank you. Thank you. Thank you. Thank you. Thank you so much.
So Mahesh, you have a meeting every Wednesday?
Yes, sir. Every Wednesday, sir, 8 to 9:30, hai, sir. And 8
Okay.
to PM to 9:30 PM. So we have different, sir, we have made different SIG, special interest group. तो पिछले महीने we had neuromuscle. तो इस महीने चल रहा है neurometabolic neurogenetics. तो ऐसे ही वो चलते रहेंगे, sir. तो we'll continue.
Yes.
And ये दोबारा भी होते रहेंगे, sir.
So I think with this, the genetics, now with this NGS, neurology has been taken to a different level.
Yes, sir.
Absolutely. Absolutely,
And
sir.
fortunately,
Yeah.
it is helping in treatment also.
Yes, sir.
Yes.
It is. Precision medicine is also coming up in a big way, and I think genetics is something
Yes.
about the future, whole body genetics, नहीं?
Yes.
तो इसलिए वो personal genomics
disciplines है.
बिल्कुल. And thank you so much, ma'am, and thank you, Dr. Gauri, and thank you, Verma sir.
Thank
so
you.
much.
Good night.
Thank
Good
you.
night.
Good
Good
night.
night.
Good night. Bye. Bye. Bye.
Okay, bye.
Sir, and all of them are recorded and put on the website, and all of them will be on the YouTube channel as well. So all of them.
Okay.
So, yeah.
They are on
Thank
your
you.
AIMS,
On-
AIMS, is that AIMS website?
No, sir. AOCN website.
AOC
sir.
India, sir.
Website, yeah.
AOCN.
AOC in India, Association of Child Neurology India, sir. I'm the president and Mahesh is the secretary currently. So,
Yeah. So no, this on that website.
on that website. Yeah.
Okay. Okay.
Yeah. Thank you, sir.
Good.
Thank you so much.
Good.
Bye.
You people are doing an excellent job.
Thank you. Good night. Good morning. You have a good day, sir.
Yeah.
And rest. Good night
Good
to
one.
everybody else. Yeah. Thank you, sir.
Okay.
Bye.
Right. Good night.
Bye. Good night.